Good morning, everyone, or good afternoon. My name is Jenny Bogard, and I am the Executive Director at the National Hypertension Control Roundtable. We are so excited that you're joining us on this very important week to celebrate our nurses, very, very critical members of any healthcare team across in every community. With that, I'm going to pass it over to our very own co-chair, who is also a nurse, Yvonne Commodore-Mensah, to welcome the panelists and moderator.
Thank you so much, Jenny. Good afternoon, good morning, everyone. As Jenny said, I'm Yvonne Commodore Mensah. I'm honored to be the co-chair for the National Hypertension Control Roundtable. And as Jenny said, it's a special week, my favorite week and month of the year. It's Nurses Week, and I'm so honored that the Roundtable has agreed to use today and the rest of the week to honor the indispensable role of nurses in hypertension control. I also want to say a big thank you to our panelists today for saying yes and helping us to spotlight the wonderful ways that nurses are making meaningful contributions to improve blood pressure control. So, without further ado, I have the honor of welcoming our moderator for today, Dr. Kate Gawlik. Dr. Gawlik is a clinical professor and nurse practitioner at the Ohio State University School of Nursing. So, without further ado, I'll turn it over to Kate, and thank you so much.
Thank you, Yvonne, and also thank you to the National Hypertension Control Roundtable for hosting this webinar. So good afternoon, everyone on the call, and welcome. We're so glad you're here to help us celebrate Nurses Week. Today's conversation is titled The Indispensable Role of Nurses in Hypertension Control, and that word indispensable is very intentional. We know that hypertension remains one of the most significant drivers of cardiovascular disease, and nurses are really at the center of every effective solution, whether it's in clinics, communities, policies, health systems. We're going to anchor our discussion today in the 2025 AHA-ACC hypertension guidelines. You'll see on the next slide the 10 key takeaways, and most importantly, we'll bring those recommendations to life through real world nursing practice. But I would like to start by introducing our panelists. So we have Alison Smith. She is a consultant to the American Heart Association and former program director at Target PP. We have Dr. Jennifer Cooper. She's an assistant professor of nursing and chair of the Department of Nursing at Hood College. We have Dr. Billy Caceres. He's an assistant professor at Columbia University School of Nursing. And we have Dr. Bunmi Ogungbe, and she is an assistant professor at Johns Hopkins School of Nursing and Johns Hopkins School of Public Health. So welcome, everyone. Okay, so to set the stage, let's look at these 10 key takeaways. You're seeing from tighter BP goals to more of this team-based care, lifestyle-first approaches, the growing role of blood pressure home monitoring. So Alison, I'd like to start with you. So what is new in the 2025 AHA-ACC hypertension guidelines specifically for the role registered nurses can play in blood pressure control?
Well, thank you for the opportunity to be with you all the panelists, as well as those participants. And I appreciate the question, Kate. I think really there's an opportunity to both leverage the skills of frontline nurses, as well as leverage the enduring trust that the public has in nurses. And I think these are untapped in two specific ways. So first, if we think about the importance of annual in-office blood pressure screening, this isn't actually a new recommendation, but as a nation, our blood pressure control rates have stalled around 50% if you measure it using 140/90 as the threshold. But if you start using 130/80, which is really the treatment goal for most adults, our control rates are pretty dismal, less than 30% probably. This stalled progress, I think, is an opportunity to rethink how we can win this public health challenge with a $50 device and low or no cost medications, and think about how we can leverage the trust and skills of nurses to engage the public in annual blood pressure screening and thinking about that as one of the first steps in blood pressure control to leverage their measurement skills, their collaborative communication, and their patient education skills. And that sort of leads me to the next point, which is that it's again not a new recommendation, but this guideline emphasizes the importance of accurate blood pressure measurement. The new guideline does emphasize the use of using validated blood pressure measurement devices that can be found on validatebp.org. And really, there's an opportunity to continue investing in nursing staff as leaders and as frontline caregivers to make sure those blood pressure measurement skills are as accurate in technique as they need to be, and that the place where they're practicing, in exam rooms, for example, are equipped and that it's possible to take an accurate blood pressure measurement. If your exam room only has as an exam table, it's not possible to take an accurate blood pressure sitting on an exam table with your arms and legs dangling. So I think nurses are well positioned to lead the workflow design and the training to make sure every place where blood pressure is measured, it has the appropriate support and that technique is accurate. So again, I think, it's an opportunity to leverage the trust and talents of frontline nurses to drive patient engagement and accurate blood pressure measurement. These are really fundamental to improving blood pressure control.
Yeah, absolutely. And would you say, from your perspective, is current policy aligned with this and with this science, or are there gaps that we still need to close?
I would say yes and no. We have made a lot of progress. There is increasing coverage for using validated blood pressure devices. There's increasing reimbursement for clinicians to oversee home blood pressure monitoring, which is essential for confirming a diagnosis. We want to measure 2 or more times on 2 or more occasions, and home measurement is a great way to do that with self-measured blood pressure monitoring. And we've had some amazing wins in terms of state Medicaid policy, making equitable care accessible to so many. Now I think about 42 states provide some coverage for home monitoring devices through Medicaid, and about 24, I believe, reimburse clinicians to continue monitoring patients on a monthly basis using the SMBP codes. And we continue to advocate in hopes that Medicare will cover devices, since we know that about 75% of older adults are likely to have hypertension.
Yeah, and so you really highlighted how central nurses are, not just in implementation, but also in shaping outcomes. So let's expand that lens more to look at the systems level work. What is new in the 2025 AHA-ACC hypertension guideline for the role that QI and population health nurses can play in blood pressure control?
That's a great question. If you reflect on this slide that you have up alone, there are a lot of opportunities to reflect on the materials that we provide to our clinical teams to drive practice, like their treatment algorithms, making sure those are tightly aligned with the most recent science and the strongest and most clear recommendations in the new guideline. And also our patient education materials. For example, in lifestyle modification, we want to make sure that stress is included in those recommendations. We want to make sure that some of the newer, more refined dietary recommendations are included. And I know my colleagues are going to talk more about that. But also your clinical teams, are we making sure that we're emphasizing the use of single pill combination therapies and the way we drive treatment and achieving control rapidly to reduce risk? So that's sort of one area, brushing up the resources, brushing off them and aligning them tightly with the most recent evidence. And I think the second opportunity is thinking about how we measure our success. The National Blood Pressure Control measure uses less than 140/90 as the definition of control, but that's not what the science recommends. And control is really defined by less than 130/80. So I would encourage organizations to start measuring their blood pressure control using that lower threshold. It's a little bit of a rude awakening if you think of yourself as a high performer and then you change the threshold and you realize you have quite a ways to go often to get patients to a level of control. And this is an opportunity, a policy opportunity, I think, for payers, for insurers, and for, health agencies who evaluate performance, to think about lowering that threshold. And then lastly, I would just say that this is an opportunity to continue looking at your data through a QI lens and stratifying it by variables that are relevant to your patient population and your community. And that may be by zip code or payer status or race or ethnicity or other variables that are unique to the individuals that you serve, to identify where is our performance and the outcomes of subgroups within our population lagging behind maybe our overall population. And I think that then leads us to solutions that meet the more unique needs of some patient populations that are different from others. So I think those are sort of three quality improvement, systematic things that we need to do to align with the guidelines. So brushing off your materials, thinking about measuring your performance using less than 130 over 80, and then also using your data to look for gaps in care. So thanks.
Yeah. All right, so Dr. Cooper, I want to shift us from systems now to communities, because many of these recommendations depend on meeting patients where they are. So when we consider these 10 key takeaways, what is the role of the community or public health nurse in hypertension prevention and control?
Yeah, great question. Thank you, Kate, and hello to everyone. I want to start by thinking, kind of putting us in the context that most of our life occurs in the community, not in a healthcare setting. So where people live, work, learn, play, and pray. And that's where we have to really, where we have nurses in the community and in public health. And the focus of that role really is prevention. So the prevention piece involves providing education about blood pressure, how to measure it at home with a monitor, and what kind of lifestyle changes people can make to improve these numbers. In my experience, and probably a lot of yours, many people do not even know what the numbers mean, and they don't know the things that they are doing or that they can change that is going to impact those numbers. So the education piece is really, really important to meeting people where they are in the community. When I look at the 10 key takeaways, things like blood pressure goal, screening, team-based care, blood pressure classification, and lifestyle first, home blood pressure monitoring, these are all things that nurses in the community and in public health can contribute to in their own communities to help to prevent or control hypertension. So doing blood pressure screening with referrals and follow-up, very important. Also coaching people through lifestyle changes. We can tell them what to do, but if we can find the time to really coach them through and encourage them and motivate them to make those changes. And all this really does include an assessment of the barriers, of things that can be barriers. So we talk a lot about social determinants or social drivers of health. These are the non-clinical factors that from my perspective, sometimes make a bigger difference than the clinical factors on the ability for people to make for the easier choice to be the healthier choice. So this is kind of fresh in my mind because recently I work at a free clinic, and what we often see or label as non-compliant patients is often due to those social determinants or those barriers that they have in making lifestyle changes or managing their condition. So I work as a triage nurse in a free clinic, and everyone there, honestly, everyone there that I see has either diabetes, hypertension, or both. Many of them don't fill their medication prescriptions to help them control these conditions because the barriers, they can't afford it, they can't get to a pharmacy, or they don't understand instructions or remember the instructions on how to take the medication. So as a nurse, I am guilty of handing paperwork to patients and just hoping and praying that they do what they need to do. And so thinking about that and solving these larger issues as to why these barriers exist sometimes feel to me like solving world peace. But I know in my community, I'm working with our clinic to take a deeper look at how we can better assess what these barriers are how we can better educate these patients and then actually follow up with them to make sure they're following their treatment plan. If I don't do this, if we don't do this, then they're back with the same issues with no change, no improvement in 3 months. And that's disheartening. So that's just a good example that's fresh in my mind of the role of the nurse in the community and in a lot of these settings.
Yeah, and that's, just so incredibly important. And, how can nurses act as advocates for change when it comes to hypertension prevention and control?
I think let your experience be the evidence that our leaders need to hear about, and that's what I try to do in my own community. One of the core functions of public health is policy development. So, as community and public health nurses, advocacy and educating leaders on the need for and the reasons for policy change or new policy is actually a nursing intervention in my world. So. It's Nurses Week, so I encourage all of you to be the voice of the patients and the populations that you work with. Unfortunately, the voice of nursing isn't always loud enough. Tell the leaders and the policymakers what the patients and the populations you work for need. And work with your professional organizations, I would say too. For me, that's the American Public Health Association or the American Association of Colleges of Nursing if you're an educator. And really, again, consider the experience that you have with individuals and the community as the evidence and education that our leaders need to make health good for everyone.
Yeah, okay. And I just want to shift a little because I know you work a lot with students. Can you talk about academic practice partnerships in the community and how these efforts are working to both prevent and control hypertension?
Yeah, great question. I work very closely, of course, with our local public health department. In a school of nursing, actually in a school of behavioral and health sciences. So we do have nursing and public health. And I want to mention, and Kate is living through in this at Ohio State University. They developed a Million Hearts Fellowship module that can be incorporated right into curriculum. So we've incorporated this into our nursing curriculum specifically for our community and public health courses. Students, I have them complete the modules so they can go out into the community and provide screening, education, and coaching, which is also part of what we do. So we work with the local health department, with the local health system. There's only one in our county, and the YMCA to provide a Million Hearts program on campus and at the local YMCA. So like I said, the students will do screening. We also provide a free home monitor, and we spend a lot of time teaching them how to use it. And then they spend the semester coaching participants to make sure they do they are choosing healthy lifestyles or making shifts in their lifestyle plans. And then we refer them to primary care if they need it. So I know financing of community initiatives is a challenge. With the academic practice partnership, we found that the academic partner can help secure funds and grants that they might need in practice. And on the other hand, when our practice partners get a grant and get funding, we can help supplement the workforce by having students go out into the community and do education and screening and those types of things. So we actually are helping our practice partners meet their outcome. And it's a valuable learning experience in public health, population health for our students in nursing and public health.
Okay, thank you. So I feel like all we hear about these days is AI and this evolving role of technology. So I'd like to turn now to Dr. Caceres. So recognizing the importance of social and cultural factors, that we see in health outcomes, what would you say are the essential skills that nurses need to meaningfully contribute to public health efforts to prevent hypertension?
Well, there's a few, but I'm glad that I followed Dr. Cooper because she covered a lot and set the stage for a lot of the things that I believe. I think nursing education has long focused on acute care and continues to focus on treatment rather than prevention. And I think that we really need to see a shift towards prevention. I think that what the COVID-19 pandemic really showed us is that we weren't really well equipped to handle the pandemic, partly because of prevention and lack of fund of public health resources, but I think entry to practice degrees, whether it's an associate's degree or bachelor's degree, master's degree, need to focus more on skills that are beyond sort of the acute centric. I think that having one course in community health, whereas potentially the only course where hopefully this isn't happening anymore. When I was in nursing school 16 years ago, we did never use the term social determinants of health. We rarely really talked about it in any of the courses other than our community health nursing course. But I think that there needs to be a sort of a reconceptualization of the role of nurses in society and moving from having nurses treat individuals and individual health outcomes to think of us as agents for population health and how we as nurses, whether you're taking care of one patient at a clinic at a time or six patients as a med surg nurse, really thinking about the things that are happening in these clinical settings have ramifications for outside and vice versa. The things that are happening outside have ramifications for whether or not a patient is considered to be compliant or resistant or other things. So I think there's a growing need for nurses. And I think one of the things that's nice is that we see a growing dual degree programs in public health and public policies for nurses to attain skills in those areas, which I think are really needed in terms of population health. And the biggest thing that Dr. Cooper really discussed is that we really need more nurses to have more decision-making authority and power in the rooms where these decisions are made, which oftentimes they're made without nurses' input. But nurses are the ones that are at the bedside. Nurses are the ones that are the first to potentially notice changes in a person's pattern from 3 months ago when they saw them in the clinic till now, or even a patient that you saw yesterday, a change from day to day. So I think a few of the skills that nurses need are the continued discussion around cultural humility and understanding sort of differences in behaviors may be attributed to cultural differences and sort of trying to understand how to work with patients and meet them where they're at in terms of making some changes. For some patients, like my grandmother, will not stop eating rice, even though she has diabetes, and she eats things that are specifically against the management of her diabetes and her hypertension. But that is just the thing she's been doing for 90 years. And so it's in terms of working with her, the thing that I deal with her is sort of talking about moderation rather than completely cutting things out of her life to manage her diseases. So I think oftentimes we take the approach of you just need to stop everything cold turkey, and that's just not really realistic from a behavioral approach. But I also think that oftentimes, particularly in research settings, you design these behavioral interventions that are very well thought out based on theory, based on nursing knowledge, but they don't actually account for the things that prevent people from engaging in behaviors, which is really has to do with social determinants. So we have this intervention right now. It's a preventative intervention that we started a few months ago. And the biggest roadblock that we've encountered for people sort of thinking about goal setting and behavior change is that they are food insecure or have financial insecurity. So we're telling them to eat more vegetables, but it's easier for them to get fast food because it's cheaper or more affordable for them. So I think it's one of the big things in terms of really thinking about from the early stages of designing interventions or new models of care, really thinking about how social determinants can be integrated into that. And I also think that really involves nurses working with community organizations and community groups to try to address some of those social factors. Um, and I think another big important thing is this idea that I absolutely, I'm going to use hate, but I do hate this. I hate when my nursing students or nurses, when I was a clinical nurse, they used to tell me that they weren't involved in politics because they weren't political and nursing wasn't political. But I think that if anything, healthcare is political. Healthcare is sort of determined based on policies and the distribution of different resources. And I think that us as nurses need to really focus more on like what policies are evidence-based and ground that in evidence and what's best for patients and not think of it so much as it being sort of endorsing one political opinion versus another, but it's really sort of basing it on data. And I think that that's a skill that we need to continue to hammer into our nursing grads and clinical practicing nurses, because I think that somewhere along the way, it's sort of gotten lost that the primary role of nurses is to take care of somebody's blood pressure and the issue at hand when it's really, I think, much more complex than that.
Oh, absolutely. And to kind of roll in that AI technology piece, how will the proliferation of AI in clinical settings influence how nurses help patients prevent and manage hypertension?
I am not an early AI adopter. For the last few years, I've gotten more into it in my research and sort of even using it in my personal life. But for a while, I was sort of like, oh, everybody's sort of into this, but I didn't really understand sort of the utility of it in practice. But I think like all innovation, AI creates challenges to nursing care, but it's likely also going to make some aspects of care and monitoring of patients easier and sort of like automate some of these things. I do not believe that AI will replace nurses. I think that you need clinical judgment and that clinical touch and one-to-one relationship with patients to actually bring about change or improve people's health outcomes. But I think there's many different areas, but I chose three that I think AI might help nurses. And some of these are focused on primary care, but also could be acute care. But I think early identification of patients at risk for developing hypertension. So I think that we see sort of this increased use of machine learning or predictive algorithms that use data both from remote monitoring, so what patients are sort of like their blood pressure at home or other things that they're reporting at home, sleep. They incorporate that as well as EHR data, some social determinants and comorbidities to sort of actually predict patients that may develop hypertension. So I think from an early prevention perspective, I think that's a potential useful tool of sort of these AI-based algorithms that nurses could sort of use to identify patients early on and particularly bring about behavior change before we may need to prescribe medications. I think from a hypertension control perspective, I think a lot of the work that I do involves remote monitoring of blood pressure and sleep and also mental health symptoms. And I think that there's ways that AI could help sort of identify patterns in data from the data that patients are collecting at home, could help identify when patients may need to either increase or lower their medication. If patients are reporting sort of through remote patient monitoring, patients may be reporting symptoms of dizziness. So maybe that's a time to sort of think about, is the patient potentially experiencing orthostatic hypotension or some other hypotension where medications potentially need to be adjusted? And then the last area is sort of this use of AI chatbots like ChatGPT and other chatbots to reinforce the teaching that happens in clinical settings. So the clinical encounters are very short, right? In primary care. So you only have a certain amount of time, but you could potentially, or hospital systems or clinics could potentially train different AI chatbots with evidence-based information, and particularly sort of the guidelines that that clinic follows, to actually then engage patients in additional education or thinking around behavior change, around medication management that is sort of developed considering safety guardrails, ethical considerations, and other things that comes from a clinical perspective. But I think all of these different three applications really require clinicians and I think nurses to be at the center of it, guiding the implementation and decision making around it so that it actually doesn't end up creating more issues for patients and clinical staff, that it actually sort of alleviates some of the load that they experience.
Yeah. So you're talking a lot about how patients are starting to do more monitoring of their health from home. So how can nurses prepare themselves to fully leverage these emerging technologies like AI or remote patient monitoring to promote hypertension control?
Yeah, so I don't think that nurses need to become programmers. I don't think nurses need to understand the underlying engineering that goes along with any of these technologies, but I think they need to be able to understand not only the ethical and policy implications of these sort of data-driven technologies, but also to be able to understand issues around security, privacy, confidentiality, which I think some patients have concerns about because it's talked a lot about in the media. So I think some of the important ways that nurses can prepare themselves is recognize that AI can be used as a tool to enhance their care. It's not meant to replace the care that nurses provide, whether that's motivational interviewing or monitoring of symptoms, et cetera. And that it's really important that data can only go so far. So you really need a clinician to be able to interpret that data and to be able to use that data to support behavior change or change in medications or the conditions of the household, whatever it may be. I think that nurses need to be able to take in the things that they're already strong in. I think things like motivational interviewing and sort of supporting patients along behavior change to be able to integrate these technologies to be able to bolster that rather than think of it as an obstacle to the care that they're providing. But I think that um, create some challenges, like I mentioned before. So, like, one of the things that we deal with all the time is patients being really super anxious about their blood pressure readings. And a blood pressure reading could go from 125, and then an hour later, they'll check it again and it's 132. And they become very concerned about that. So, I think there's a lot of sort of health literacy and education that needs to go along before patients can use these technologies. Because otherwise, what we're dealing with is very anxious patients running around either being afraid of calling their providers or calling their providers a lot because their blood pressure readings have changed by like a few points. But I think um, all of this is going to require nurses to, particularly practicing nurses, to gain additional training, not only in health education and understanding health literacy, but also understanding telehealth and informatics and how those things potentially impact care. But I think at the end of the day, it's sort of a quality improvement issue in a lot of it sort of ends up creating quality improvement issues. So I don't think that practicing nurses now need to go out and get certifications and degrees, but I think that some of the continuing education that they do should incorporate gaining foundational knowledge in some of these technologies.
Yeah. Well, let's widen this, and I'm just going to open this up to, any of our panelists. But where do you see the biggest opportunities and the biggest risks for AI in hypertension care, specifically for nursing?
I mean, I can just comment briefly to say I think it's a tool that can leverage nursing time by perhaps translating materials into languages that you don't have at your fingertips to make sure and to translate materials into reading levels that are appropriate for your patient population. I think those are sort of the lowest hanging fruit in providing, equitable access to education. And sometimes those tools can be very useful in doing that. I know some of the early studies that have looked at patient education and the quality of the content that comes out of AI and comparing it to the instructions given by an expert clinician. In many of those studies, they are as good at AI is as good as or better in expressing concepts in clear, plain language. So that's sort of a starting point.
I mean,
Okay.
I discussed this earlier briefly, but this idea of developing safeguards within the AI system, where if participants are reporting, I don't know, severe mental distress, or they're asking the AI to tell them like, should I take my Lasix today or should I skip it? Like those kinds of things should prompt some sort of alert to a clinician to step in. So I think that AI is good, but it can only go so far, and AI doesn't know when to stop itself. So I think clinicians are the ones that I think need to help engineers and data scientists that are developing these systems actually identify like what's safe and what's not safe and when a clinician needs to be sort of called or prompted or emailed, whatever. There needs to be sort of like some system to prompt a clinician to step in.
Well, and that we're making sure we're training those AI tools with valid evidence, because there's
Yeah.
certainly tons of misinformation out there. There are a lot of, home remedies that we've heard about for hypertension control that are not based in science. We need to make sure that our AI's tools are learning from the current literature and legitimate science.
All right. Dr. Ogunji, I'd love to bring you in here, especially around implementation and equity. So for communities facing food insecurity, structural racism, limited healthcare access, how realistic is the vision of hypertension control and what needs to change to make it real?
Thank you very much. It's very lovely to be here and wonderful discussion so far. I think it's important to ground all of those in the reality that people that we've all found ourselves in terms of people live through all of these experiences. There are people in this country who do not have access to healthcare, do not have access to high quality healthcare. There are people who they come to see us and we tell them repeatedly, this is how to achieve a low sodium diet, and this is what you should be eating. And these are things that have happened to me myself. I've had clinicians tell me, we think you should eat more of this, right? But without the further, well, how do people get more of that? Or what does that mean in the context of your culture or background where that particular meal, whatever it may be, is just not a feature, it's just not part of their regular diet. So understanding the context within which people live, we've talked a lot about social drivers of health, is really important. And doing this in the in a way that is compassionate would really help us then to start to think about, now that we have and we've defined the problems, how do we begin to prefer solutions to this? And I think, I guess, to answer the question really simply, it's being very mindful of a multi-level model where we are not just addressing one thing at one level for that particular patient or their household, but we are thinking really holistically about some of the other issues that they may have, and trying to prefer solutions to that. In some of the work that I do, with food insecurity, food is medicine trials, some of the things that we try to do is, yes, we may be addressing food access issues that people may have, or diet-related chronic conditions that they may have, because these are often participants who have hypertension and uncontrolled blood pressure. But how about someone who is food insecure and they don't even have the utilities to make the food we are giving to them? Because we do produce prescriptions, so we actually hand them the produce, but they don't have stable housing to even cook that, right? How do we address that? So ensuring that for every person that we are talking to about lowered blood pressure, about, low sodium diet, whatever, the lifestyle, even medication, we are also following up with the questions of, do you really know do you have a place to access this? We are really assessing their social needs. We are not just stopping at handling them pamphlets, but we are actually ensuring they are plugged in to the resources that they may need. It could be ensuring that they have access to CHWs, if the health system has that cadre of healthcare workers. It could mean ensuring that when they come back, we actually reassess and say, did you get access to some of these services? So anyway, I think it's important for us to not just talk abstractly about this, but really get down, get into the community, assess, speak with people, understand what their needs are, understand what their realities are, and prefer straightforward, simple solutions that would meet their needs.
Yeah, and all of us have been talking a lot about social determinants, social drivers of health, but what does that actually look like on the ground? And are we adequately training our nurses to do this work?
It's truly, I wouldn't speak to the adequacy of this, but I would speak to a little bit of successes that we've had, in the sense that it is true that a few short years ago, we weren't even talking about this. Actually, people were outrightly dispelling, or people were shying away from the reality of non-medical factors that does affect people's health. There was a lot of people, and I think there continues to be a lot of people who argue for the biological mechanism of it. People try to say, how do you mean that the person's, housing situation is impacting their blood pressure? How do you link all of that? And we've had a lot of publication, a lot of evidence that has been generated over the years to actually make both the social and the biological links between all of this and really present the evidence. So I personally, I think, maybe I'll speak for me and my team. We're sort of done convincing people that this is important, or that this is something that we really should focus on. I think we have a wealth of evidence that already shows that. And I think it's important for us to start to move more into solution-oriented strategies, right? You had asked me previously about implementation science. There are real-world solutions that we don't have to only stay within clinical trial environment, right? We can use a lot of implementation science strategies to ground solutions, to ground a lot of this research in the community, in people's homes, right? And actually see how, some of the outcomes, positive outcomes, hopefully. So there are ways to do that. But I think the other part is, speaking to the education part, is that I think it's not just enough to isolate our teaching, our clinical instruction, especially for nurses, and to remain in the clinical space. I don't know if you know what I mean. I mean that we need to expose nursing students early to all the strategies. We need to expose them early to community-based or community-engaged programs or research, whatever it may be. We need to sort of help them understand that it doesn't stop at the med-surg unit, right? Because at that point, people they've already progressed through their conditions. It may actually be at the point where, people are at stage 2 hypertension. There is much that we still can do, but if we're going to focus on prevention, and we've talked on this panel about how that happens outside of the hospital. So why don't we incorporate that into a lot of our teaching curriculums and bring students out early into the community? There are different models. I know there are people who do, I don't want to mention specific programs because I don't want to leave some important ones out, but there are a lot of programs and there are a lot of schools of nursing developing programs where they have community health and community and public health as sort of central to what they're doing. And it's important to have nursing students be part of that very early.
Absolutely. And I know that you've done a lot of work, across the US and globally. What is the rest of the world doing, for hypertension control that nurses here should be paying attention to?
Very fantastic question. So and a few of my colleagues, we talk a lot about this concept of reciprocal innovation, which is the idea that we can learn from each other across countries, across regions. It could be that there are some solutions, some interventions, some model of care, some nursing intervention that has been developed and that has shown positive outcomes in X country. There's no reason why we can't look very critically at our intervention and think about how we can adapt that in this country. So yes, there are a lot of that. Team-based care is one of them. There are countries where, as a result of the need for healthcare professionals, they quickly realized that they can wait for, one person who is a specialist to see millions of people. There are countries where it's one physician or one nurse to thousands of people in terms of the ratio. They just don't have enough. So they quickly understood that how about we think more of a team-based care approach where we have community health workers actually going into people's houses to measure their blood pressure and help them with ensuring that they get their medication, right? Where they quickly understand that nurses could be part of the team titrating titrating medications for uncomplicated hypertension, and we are actually testing some of that out in one of our trial in Ghana and Nigeria. So the point is yes, some of the solutions may have developed out of a specific need, but they are great solutions and they are working fantastically, and we can adapt that in this country. Maybe not just rural areas. Oftentimes we're like, yeah, we can do it in our rural areas where people don't have access, but even in urban communities where people still do not have access, for various reasons, there are ways that we can do that. We talked about AI earlier, and one thing I do want to chime in as far as that is concerned is it's truly an opportunity. Yes, there are risks, and I think it's important for us to talk about the safety layer that has to be in place when we do incorporate AI-based solutions. But from some of the work that our team has been doing, we have seen a lot of opportunities for remote monitoring and companionship. And, some of the work that we're doing, it has an AI-enabled heart health companionship to it. And the idea is if we see a patient today and we don't see them in 6 months, we don't see them in another year, we really don't know what their blood pressure is doing. Yes, sometimes we give them home blood pressure monitors, but sometimes we're not even getting those readings, right? There's so much huge barriers to be able to even get some of the readings that people are measuring at home to us. But some of the AI-based solutions are really helping us to do that. They're helping us doing the daily nudges, the behavioral nudges. How many minutes did you walk today? Did you check your blood pressure today? Just things that really doesn't constitute the AI agent giving medical advice, but just doing a bit of that behavioral change and helping people to understand that the constant reminder, the accountability does help and moves them towards a life where they have a healthier heart than not. So anyway, I can talk a lot about there are so many examples, but I think it's important to keep in mind that concepts like reciprocal innovation does help all of us across countries and across regions, and we can learn from other nurses and other nurse-led strategies outside of where we are.
Yeah, absolutely. And so now I just want to, open this up again to all of our panelists. But, if every nurse watching today took one action that went beyond their clinic walls, what would you want that to be?
I'll jump in and say I think we have another slide here that we might want to move to, and it really illustrates all the roles, the many roles that nurses can play in different capacities. And I think everyone around the circle, whether it's registered nurses, QI, population health nurses, those who are members of or lead professional or nursing organizations, schools of nursing, or who are advanced practitioners who are frontline clinicians who diagnose and treat patients with hypertension, prioritizing hypertension in any of those roles, I think is important, and sort of working at the maximum capacity of your scope and making hypertension sort of a top priority. It affects nearly half your patients. There's no greater way to save lives, reduce risk, eliminate avoidable pain and suffering than by controlling blood pressure. Cardiovascular disease remains the number one cause of death, and hypertension remains the number one contributor to the cardiovascular disease. So I think making it a priority, realizing that nurses are always wearing many hats. We have patients with many conditions that we're juggling, and we have many responsibilities. But I think this is an investment in an area of focus that will not only benefit our control of hypertension, but so many other conditions, especially if we approach the solutions with policy solutions and other systematic approaches.
Thank you. And, what is one specific change that nurses could make, even tomorrow, that would have the greatest impact on hypertension control?
I can start. There was something that Billy had said earlier, the sort of, the political part of this, and I would just start there. Understanding that if people say that they want to remain apolitical, it is a choice. And decisions are being made in their names. Either they contribute to it or not. A lot of decisions about healthcare, about how healthcare is funded, about how, whether we're centering hypertension control or not. Those decisions are being made in their names. And so one thing that I think maybe everybody can do, regardless of whether they're working clinically or in research or whatever domain of nursing, is to take that political step. It could be finding out what, as Alison was mentioning, what their state is doing regarding hypertension in particular. If there is a rep that they want to call and say, look, about more than 50% of people who live around in our districts do have uncontrolled blood pressure. What can we do about that? And as a nurse, I want to be part of that. Being part of conversations like this, being part of, organizations around them. There's PCNA, the Preventive Cardiovascular Nurse Association, that does a lot of work in this area. There's AHA, there's APHA, a lot of associations. Being part of the whatever they have set up to address blood pressure control. And I do want to shout out Alison because she probably has specific names or organizations that people can reach out to if they want to take that stand. So I think it's important to take that step.
Absolutely.
Kate, I just wanted to say for schools of nursing, something that we really need to do is focus on non-traditional settings. Yes, we have to give them in schools of nursing that med-surg rotation in the undergraduate so that they're generalists when they come out. But we think a lot about when it comes to hypertension control. Our community health course, we have students this fall that will be going into public libraries to see people, and that really gives them an exposure to what some of these barriers are for them to access care and to make healthy choices. But think of your women's health maternity courses. If you have nurses that do home visits, that's a great place for students to go and see some of those social determinants and also teach preventive actions that people can take. Your leadership courses, where we can talk more about nurses' involvement in policy and advocacy. So think non-traditional is what I would say when it comes to schools of nursing and their role and how we can prioritize hypertension control.
Absolutely. So now we are at the point where we can open up the floor to discussion from the audience. So if you have any questions for any of our panelists, if you want to post those questions in the chat box, that would be great.
As we do that, can I just quickly extend something that Jennifer just said in terms of thinking non-traditionally? So our team started a blood pressure control program in beauty salons, and we're seeing a lot of opportunity to also nest maternal related programs and perimenopause focused programs. So thinking about, and we're looking to expand, we're looking to talk to schools of nursing or other people who may be interested in that work because it's such a powerful place to meet people where they are and then talk about blood pressure. We're setting it up in a way that each salon has a blood pressure device for people to walk in, even if they're just, they are just going to be there for 2 minutes, 5 minutes, whatever it may be. They can check their blood pressure. So that's I just wanted to second that and say there are like just straightforward community settings, safe spaces that already exist in the community that we could nest a lot of blood pressure control initiatives.
I'll
Yeah,
just build on that point, Bunmi. There's so many great examples to your point, leveraging libraries, dental offices, a place where patients may be more likely to go for routine care for their dental health and their overall medical health. And I think as long as we're really thoughtful as nurses in building those trusted relationships, trying to build skills so that that screening happens in an accurate way, but also building those referral pathways to get patients back to clinical care, so that we use those opportunities to raise awareness and engagement, but getting them into clinical care so that we can reduce risk rapidly. That's where, that's really what, it's not the device that improves blood pressure control. It's not the measurement of it alone, but those are essential starting points to get people to care so we can actually reduce risk.
These are all great points. So I don't know, what I'm taking away, is that really hypertension control isn't just about the numbers, it's about our relationships, our systems, equity, trust, and nurses are really at the center of all of that. We are not seeing any questions in the chat, so I would like to take this opportunity again to thank our panelists and to say to everyone, Happy Nurses Week. Thank you to everybody, not just for today's discussion, but also for the work that you do every day. And I will now turn it back over to Jenny.
Great. Thank you, everyone. This was a fantastic conversation. I appreciate each and every one of you. Thank you to our panelists, and I appreciate all the nurses out there who are continuing to show up for your patients and your members in your own community. You are all amazing. Thank you for the hard work you do. I hope you have a wonderful week. I hope we can celebrate you all year long and not just this one week. So thank you, everyone. We will be sending out this recording to everybody who registered soon, and it'll be up on our YouTube site. In the meantime, have a wonderful afternoon and a great weekend. Bye, everyone.